Hello everyone, welcome back to Ophtho. Today we are going to discuss one of the most common yet one of the most confusing presentations in ophthalmology, and that is red eye. Now let me ask you a simple question. Imagine you are working in the emergency department and patient walks and says, "My eye has become red since morning." What would be your first thought? Because every red eye looks similar from a distance, but the underlying diseases are completely different. One patient may have simple viral conjunctivitis and will recover within a few days. Another patient may have an acute angle glaucoma and could become permanently blind if treatment is delayed by only a few hours. Another patient may have herpetic keratitis, where giving topical steroids can actually worsen the infection and permanently scar the cornea. Another patient may have anterior uveitis, where the redness is actually a sign of intraocular inflammation rather than an infection. So, the question is, how we differentiate these patients? How can we confidently tell which patient is safe to treat in primary care, which patient requires urgent referral, and which patient is a true ophthalmic emergency? Today, I'm going to teach you exactly this approach. So, rather than discussing individual diseases, I'd like to look carefully at this flowchart. Don't worry if it looks complicated at first. By the end of this lecture, you will understand it completely. In fact, after today's session, whenever a patient presents with a red eye, this entire algorithm could automatically start running in your mind. So, today's lecture is not simply about learning diseases, it is about the clinical reasoning. I want you to think exactly like an ophthalmologist. Whether you are an MBBS student preparing for your professional exam, a postgraduate resident preparing for FCPS, MCPS, FRCS, or a general practitioner working in your clinic, my goal is that after today's lecture, whenever you see a patient with a red eye, you will immediately know what questions to ask, what examination to perform, what diagnosis to suspect, and whether that patient can safely be managed in your clinic or need urgent referral. So let's understand this flowchart. The first step is, if the patient presents to you with a red eye, always or ask about the vision. If the patient is having decreased vision along with the red eye, then the differential diagnoses are completely different. And if the patient is having only red eye and there is not associated with decreased vision, then the differential diagnosis is completely different. So let's discuss, if the patient is having redness and there is no decrease in vision, then you can stain the cornea. If there is no staining, then you can just analyze the type of discharge and the type of reaction on conjunctiva. You can ask the patient if the discharge is watery, mucoid, or mucopurulent. If the patient is having watery discharge, then you can think about the viral or the allergic conjunctivitis. And in between these two, you can differentiate by the reaction. If there is a follicular reaction, then the patient may have viral conjunctivitis. Or if there is papillary reaction or giant papillas, then you can think about the allergic conjunctivitis. If the patient is having mucoid discharge, then you can think about the dry eye or the chronic allergic reactions. Or if the patient is mucopurulent discharge, then you can think about the bacterial conjunctivitis. And if a patient presents with red eye, there is no decreased vision, but when you stain the cornea with the fluorescein, then always examine about the pattern of uptake. If there is a dendritic pattern, then always think about the herpetic keratitis. If there is a linear pattern, then you can think about the corneal abrasion. And if there are punctate epithelial erosions, then you can think about the superficial punctate keratitis. And if the patient presents to you with red eye and there is decreased vision, then always examine the pupils of the patient. If the pupil is constricted to light or if the pupil is semi-dilated or dilated. If the patient is having constricted, irregular myose pupil, then always think about the anterior uveitis. And if the patient is having red eye with decreased vision, circumcorneal congestion, and the pupil is semi-dilated or mid-dilated, and the patient is also having history of halos and severe pain, nausea, vomiting, then always think about the acute angle closure glaucoma. So, this algorithm simplifies the diagnosis into just four important clinical questions. Has the patient's vision decreased? If the vision is decreased, what does the pupil look like? If the vision is normal, does the cornea stain with fluorescein? And if the cornea is normal, what type of discharge is present? These four simple questions can differentiate the majority of the common causes of red eye encountered in examinations, emergency department, outpatient clinics, and primary care settings. So, once you master this algorithm, you will never feel confused when evaluating a patient with red eye. If you like this video, then please subscribe my channel. Thank you.